I would like to now welcome our next speaker, Eedy Mezer, who will discuss intermittent strabismus, more a basic presentation. And Eedy is a pediatric ophthalmologist from Israel. Eedy, please go ahead.
This talk is intended to show only some of the many types of ocular misalignment that may manifest intermittently and not in all positions of gaze. I will address conditions that parents might report as an intermittent eye misalignment. Therefore, this will cover not only traditional types, such as intermittent exotropia, seen in this slide. Intermittent strabismus in this presentation denotes any eye misalignment that is not seen all the time. It is sometimes present from birth and manifests only when the baby starts to fix on and follow visual targets. Or it may persist or appear at a later age. Therefore, both teenagers and adults may also have intermittent strabismus and not only children. Intermittent strabismus is not necessarily sinister. Some types, however, may deteriorate to a constant tropia. This in turn can induce a lazy eye if it occurs during the first years of life. The tropia or amblyopia may induce social rejection and lead to a low self-esteem. Moreover, both may result in long-term psychological implications. When does intermittent strabismus manifest? It may occur occasionally in primary position under certain conditions, when the subject is tired or daydreams. In other instances, it may manifest on side gazes. Please refer anyone, especially a child with suspected intermittent strabismus, to a pediatric ophthalmology unit for a full orthoptic assessment. So, here are a few examples to illustrate intermittent strabismus. First, we will discuss the cases that are seen in primary position. Cyclic esotropia is an uncommon condition of alternation between orthotropia and esotropia. It occurs in regular intervals, usually every day. Observe the left esotropia on day 1, orthotropia on day 2, recurrence of the left esotropia on day 3, orthotropia on day 4, and again the left esotropia on day 5. It may appear spontaneously after orbital or ocular trauma or surgery, or due to neurological causes. It is amenable to treatment, such as surgery or botulinum toxin injection. Many small babies have epicanthal folds or telecanthus that makes their eyes look crossed. The baby in the picture may look like he has esotropia. However, the telltale that the child is orthotropic is a corneal reflex that is central in both eyes. Some children have accommodative esotropia and may seem to have an intermittent esotropia when they do not put on their glasses. Notice the left esotropia in this child. Cycloplegic refraction reveals a high hypermetropic refractive error, +7 diopters in the right eye and +8 in the left eye. When the child wears a full hypermetropic correction, the need to accommodate disappears and the eyes become straight. A subclass of accommodative esotropia are children with a high accommodation to convergence ratio. They have more esotropia at near, as we can see in this case. Bifocals or progressive addition lenses will eliminate the esotropia at near. Again, the unaware parent will report that the child has intermittent strabismus when he takes off his glasses, especially when he looks up close. The classical example of intermittent strabismus is shown in this case. The baby has intermittent exotropia that alternates between the right and the left eyes. Some cases may improve over time or stay stable, while others will deteriorate to a constant exotropia and will need surgery. The exotropia is mostly seen when the child daydreams, becomes tired, or is exposed to bright daylight. DVD, or dissociated vertical deviation, is part of the infantile strabismus complex, or occurs following other congenital causes that disrupts early development of binocular vision. It manifests when the subject daydreams or when the affected eye is occluded. Most often, This represents a benign condition that does not require a neurological workout. The following example will illustrate intermittent strabismus that is apparent only on side gazes. In wide pattern exotropia, we can see that there is no ocular deviation in primary position. However, it becomes visible when the patient looks straight up, when he looks to the right, and when he looks to the left. The Y pattern is one of several types of alphabet pattern strabismus. A Y pattern strabismus might be due to several possibilities, often due to an overaction of the inferior oblique muscles, as we can see in these photographs. And sometimes it may occur secondarily to craniofacial syndromes. In congenital fourth nerve palsy, the child appears orthotropic on right head tilt or left gaze. The deviation becomes apparent in primary position, as well as on right gaze or left head tilt. Many patients adopt a compensatory head posture to align their eyes. In Brown syndrome, the strabismus manifests when the patient tries to elevate the eyes in adduction. The inability to elevate the eye is secondary to problems involving the superior oblique tendon or sheath in the area of the trochlea. It may be secondary to congenital or acquired causes, such as trauma, surgery, or inflammation. Duane syndrome is one of several congenital cranial disinnervation syndromes and represents a clinical spectrum that is usually non-progressive. In this case, dysgenesis of the abducens nerve nucleus leads to an aberrant innervation of the lateral rectus muscle by the third cranial nerve. This condition can manifest in several ways. In this example, the eyes in primary position are straight. However, we can see both an upshoot and downshoot in adduction of the left eye. And lastly, we can observe a limitation in abduction. The take-home message is to refer any patient of yours, especially children, with a reported intermittent strabismus to a pediatric ophthalmology team. This will allow to rule out a true ocular misalignment and detect or prevent potential amblyopia and psychosocial problems. Thank you for your attention.
Thank you, Eedy, for this nice overview and presentation. One of the things I have learned over the years is that technology becomes more helpful. Often the parents say, well, when their little child is tired or cranky, then they see that the eyes are not straight. And when they're in my examination room, everything seems to be normal, orthotropic, etc., etc. And then some of these parents are so clever to make a video or a flash photograph when the strabismus is occurring. And I think that will be a really helpful, because nowadays all parents and most of the children have a mobile phone which you can make a video.
Yes, I agree. I encourage parents to send me an email with the attached video clips or stills, or they show me on the spot. They take out their phones and show me an example. Yeah. So this is.
And what is also quite reassuring that some of these patients, especially the younger than 1 year old, they come in with pseudo-esotropia, and then I show the parents take a flash photograph and then look where the reflection of the flash photo is, and then explain them that it's not the amount of conjunctiva which you can see nasally compared to temporally, that shows the strabismus, but that where the both eyes are fixating, that's where there is either real strabismus or pseudostrabismus.
Yes,
John, do
I
you
agree.
have any? John, do you have any more questions for Eedy?
Yeah, Eedy, what are your indications for doing surgery in a child with intermittent exotropia?
Well, it depends if it's a child, if it's a teenager, if it's an adult, because I look at several factors. The classical factors, more than 50% of the time of manifest strabismus, with the deterioration of visual faculties such as stereo acuity or amblyopia. But I also take into account beyond the androgenic age, social discrimination and emotional considerations. So it's not enough to have most of the time distant manifest strabismus and choroid near, but I need those additional factors.
Right, thank you.